my presentation today about central serous chororetinopathy. Central serous chororetinopathy is a posterior macular disorder characterized by subretinal detachment and focal or multifocal retinal pigment epithelial defect. Sorry. Prevalence of this disease is most common vision-threatening retinopathy after age-related macular degeneration, diabetes, retinopathy, and branch retinal vein occlusion. High prevalence among men was observed in several studies with 70 to 88% of cases occurring in male subject, 6 times higher incidence in men than women, age-affected patient ranging between 39 to 51 years. It can happen after 33 years in special ethnic groups. Suspected higher frequency among Asian and Caucasian and Hispanic as compared to African American was not confirmed in all studies. More severe form of central serous chororetinopathy with lower visual acuity seems to affect African American subject. In Asian population, central serous is frequent and severe with bilateral multifocal forms being reported more frequently than other ethnic groups. Risk factors, genetic predisposition. There is strong evidence for genetic contribution to the pathogenesis of central serous comes from observation that in 14 out of 27 families of central serous chororetinopathy patient, 52%, at least one relative presented multiple area of RBE atrophy or fundus lesions, suggestive chronic central serous chororetinopathy. To date, no clear transmission pattern and no specific genotype have been associated to central serous chororetinopathy. In recent analysis of 5 families, 50% of eyes from relative of central serous chororetinopathy patient had choroidal thicker than 395 millimeter, suggesting to pachychoroid could be inherited condition with possible dominant transmission pattern. Cardiovascular disease and hypertension associated with central serous chororetinopathy. Also, the cardiac disease, ischemic heart disease also associated. Sympathetic, parasympathetic imbalance observed in central serous chororetinopathy patient and assisted by measures of blood pressure, heart rate variability. Corticosteroids is a major risk factors when the patient exposed for systemic or local corticosteroid. Local of nasal spray or periauricular or any local treatment of steroid, it can induce central serous. Endocrine changes like pregnancy, especially in 3rd trimesters, also it can be resolved after delivery. Also associated with cushingoid patient. Psychopathy, it was observed by 1985, and there is type A personality pattern characterized by competitive drive, sense of urgency, aggressive nature, also antipsychotic medication and psychological stress. It was independent risk factors and associated with central serous, also associated with recurrent attacks of central serous. Gastroesophageal disorder like gastroesophageal reflux or peptic ulcer and several studies also reported high prevalence of Helicobacter pylori infection. this is suggested immune-mediated damage to choroidal endothelial cells mechanism. Drugs associated other than steroid, like adrenergic receptors antagonist, like zidofedrin and oxymetazoline, contained in nasal spray. Sleep disturbances like obstructive sleep apnea. It was reported in 22% of central serous chororetinopathy patients, and suggested of increased catecholamine secretion in those patients. Types of central serous chororetinopathy. Acute central serous chororetinopathy or classic central serous chororetinopathy is characterized by subretinal detachment localized at the posterior bole and multifocal or focal RBE changes, and confirmed by fluorescein angiography with focal leakage. The acute disease is self-resolving within 3 to 4 months from the onset of symptoms. This is mid-phase of fluorescein angiography. There is focal leakage of fluorescein in the left eye. Also there is subretinal detachment in the left eye. This is the symptomatic eye, but also the left there is focal lesions with asymptomatic patient. This eye is 6/6. It is extrafoveal subretinal detachment. Non-resolving central serous chororetinopathy or persistent central serous is acute presentation, but the duration longer than 4 months after onset of the symptoms, often associated with elongated photoreceptors outer segment on spectral domain OCT. You see in this OCT the outer segment of photoreceptors elongated more than normal, and the frequent visits, the subretinal fluid decreased. Also there is some subretinal deposit at the area of detachment. Recurrent central serous, this is episode of acute following previous episode with complete subretinal detachment resolution. A chronic or diffuse retinal epitheliopathy or diffuse RBE epitheliopathy is a chronic stage with diffuse RBE decompensation. It can presented with active disease or inactive. The active disease is associated with subretinal detachment and active leak. The inactive, no subretinal detachment and no leakage site. This is RBE atrophy with active leaking in this patient with chronic central serous. Also there is gravitational defect of RBE. Also there is subretinal detachment and thick choroid. This is signs of chronicity with RBE changes, but no active leaking. Also with ICG there is RBE atrophy is affected of the posterior bole. Also no subretinal fluid and no activity. Aggressive form of chronic central serous characterized by bullous subretinal detachment and massive exudation with the subretinal fibrin deposition seen more frequently in Asian population and are exacerbated by systemic corticosteroid treatment, as it occurs when is misdiagnosed for inflammatory chororetinal disorder. Inactive disease when the patient history of acute central cirrus but without any subretinal detachment at the time of evaluation. Not all patients with acute central cirrus go to developed chronic disease, and the reason for ferret courses are not well understood. There may be additional unknown differences in the pathophysiology of acute and chronic disease. Pathophysiology, the main pathophysiology confirmed is hyperpermeable choroidal vessels are thought to produce increased tissue hydrostatic pressure, which permit the formation of retinal pigment epithelial detachment, offer hence the barrier function of RPE and lead to area of fluid accumulation between retina and RPE. The evidence of choroidal vasculopathy in central serous choroidopathy is strong, but the underlying mechanism of choroidal disease remains to be determined. The second theory, retinal pigment epithelial theory of pathogenesis. Retinal pigment epithelial dysfunction play a significant role in pathogenesis of the disease. This is perhaps most easily appreciated in cases of diffuse RPE. Widespread loss of RPE cells is apparent on clinical exam and autofluorescent, and where the loss of RPE barrier and pumping function in the setting of engaged choroidal result in chronic subretinal fluid. Alternate theory is the focal loss of polarity of RPE cells lead to active fluid pumping into subretinal space. The role of RPE in central serous chororetinopathy pathogenesis remain poorly understood. Some refer to the pinpoint area of leakage seen in acute central serous as microrib, and pigment epithelial detachment are common in central serous and could also represent from form of RPE decompensation in response to high choroidal hydrostatic pressure. The third theory affected central serous, it can be caused by aldosterone mineralocorticoid receptor pathway, and there is strong association between glucocorticoid and central serous chororetinopathy, suggests the role in the pathogenesis, especially glucocorticoid receptors and mineralocorticoid receptors are co-expressed in many cell types. Also, they interact at molecular and functional level synergetically or competitively affected the balance. This is the retinal layers. This is the photoreceptors, retinal pigment epithelial and choroid. Choroidal layers, and the aldosterone and corticosteroid competitive adherent to mineralocorticoid receptors. It can express to RNA and produce special proteins. These proteins, it can affect of vascular choroidal vessels and induce vasodilation. Low doses of aldosterone have been shown to exert direct effect on vascular system by induce oxidative stress, inflammation, hypertrophic remodeling, fibrosis, and endothelial dysfunction, demonstrating that activation of mineralocorticoid pathway. Following injury of vessels, mineralocorticoid receptors activation has been shown to permit smooth muscle cell fibrosis via activation, placental growth factors, and VEGF receptor 1 pathway. Also, aldosterone and glucocorticoid effect of many organs in the system. It can affect the retinal layers by produce retinal edema, affecting retinal ganglion, glial molar cells. It can affect the vascularity of choroidal vessels by inflammation and stiffness, fibrosis, vascular reactivity, increase the choroidal permeability and induce RBE defect and subretinal detachment. Also, it can affect the brain and heart, also kidney. Experimental used intravitreal aldosterone injection induce swelling of retinal glial molar cells, vasodilatation and leakage of choroidal vessels with elongation of retinal pigment epithelial cells, increase the choroidal thickness and accumulation of subretinal fluid, like central serous chororetinopathy phenotype. Based on this preclinical result, mineralocorticoid antagonists were proposed as a treatment for central serous chororetinopathy patient with persistent subretinal fluid as systemic medication. The symptomatic patient presented with sudden onset of blurred vision, micropsia, metamorphopsia, relative scotoma, reduced contrast, vision ranging between 20/20 to 20/200. The decreased vision can often be corrected by hyperopic correction. In rare cases, these symptoms are combined by migraine-like headache. Natural cause and management, the visual prognosis of central serous is usually good except in chronic and recurrent cases and in cases of bullous central serous choroiditis. Most eyes improved 80 to 90% within 3 to 4 months. Recovery of visual acuity take time, at least 1 year. Recurrent are common and however occurring in 30 to 50% of patients within 1 year. Small percent of patients have poor visual outcome. Patients with frequent recurrence or chronic neurosensory retinal detachment may develop RBE atrophy, neurosensory retinal changes that result in permanent loss of visual function, include visual acuity, color vision, and contrast sensitivity. Treatment, the main treatment is observation, is standard initial management in most cases of acute or classic central serous, but there are instances when the treatment may be needed, include patient with persistent subretinal fluid more than 3 months. Rapid recovery of vision is required for occupational or other reasons. Untreated central serous has previously resulted in poor visual outcome in fellow eye. Also, patients who experience multiple recurrent attacks. The aims of treatment of central serous to induce reattachment of neurosensory retina, improve or preserve visual acuity, and prevent recurrences. Risk factor modification must frequently consist of discontinuing corticosteroid use. About 90% had resolution of subretinal fluid and RBE leaks after discontinue of steroid, with approximately 14% of eyes requiring treatment. Type A personality, it has been suggested that activities to reduce overall stress level may be benefit, however their utility has not been established. Photodynamic therapy is not only promoting resolution of acute central serous, but also preventing recurrences. Studies in chronic disease have a good result as well. But also BDT have risk to develop the choroidal ischemia, RBE atrophy, iatrogenic choroidal neovascularization, RBE rib, also be reported after standard BDT therapy. The risk, it can be going down by decrease the fluence of BDT, by reduce the fluence treatment, it can be by decrease the laser treatment time, decrease the power, and altering the interval between infusion and laser treatment. They found no difference in the rate of vision improvement or fluid resolution, and this complication can be decreased by decrease the fluence effect. Also, BDT has been shown to induce choroidal vascular remodeling and thinning of treated choroid. And central serous chororetinopathy, even half fluence BDT has been shown to reduce choroidal vascular congestion and decrease subfoveal choroidal thickness. The midface of ICG suggestive of choroidal hyperpermeability disappear after treatment with half fluence BDT. Anti-VEGF agents are not considered first line of treatment for either acute or chronic central serous, but several small trials have suggestive results. Also, VEGF levels are not elevated in equal sample from central serous eyes. Some have hypothesized that hypoxic condition in the choroid or RBE could lead to activation of VEGF expression not detected in equal sample. Anti-VEGF therapy was proposed to reduce choroidal hyperpermeability. A recent meta-analysis of 4 studies, including acute and chronic central serous, showed that either visual acuity or central macular thickness were significantly improved 6 months after intravitreal bevacizumab compared to observation BDT or laser photocoagulation. But few cases serious indicate beneficial effect of bevacizumab, ranibizumab, and aflibercept on choroidal neovascularization, complicated chronic central serous choroidopathy. Laser photocoagulation, either green or yellow, has been attempted to seal the RBE leakage point. Besides direct thermal sealing affect the focal RBE defect, laser is thought to promote fluid exit and favor expansion of surrounding RBE cells, but laser photocoagulation is not expected to act on choroidal congestion and hyperpermeability. Several studies have compared laser photocoagulation to observation or sham laser treatment. Overall, the studies showed that in acute central serous choroidopathy with obvious focal leakage and fluorescein, laser photocoagulation decreased the resolution of neurosensory retinal detachment, but did not improve the final visual outcome. All these studies, the visual acuity is not improving on all the studies. Also, the recurrences is not decreased, except in the second study and the fourth or the sixth. To date, laser photocoagulation remains an option in acute central serous choroidopathy. Patient with subretinal detachment persisted for more than 4 months and a clear leak on fluorescein angiography located more than 500 micron away from the fovea. Subthreshold diode micro pulse laser, it is a long wave laser, allows better choroidal penetration and sparing the inner retina from laser injury. There is a randomized control trial by Ferma and colleague, a randomized acute central serous patient with single focal leak to diode micropulse laser or standard argon laser. All 30 eyes had resolution of fluid and similar final visual acuity at 12 weeks, but the diode group had significant better final contrast sensitivity. Patient reported no persistent scotoma. Versus 3/15 with persistent scotoma and argon laser. Primary outcome measure for this study is not specific, and larger studies should confirm this preliminary finding. Systemic oral treatment has been investigated as a treatment for central cirrus on basis that inhibition of carbonic anhydrase in RBE seems to promote resorption of subretinal fluid and retinal adhesions. The clinical study investigating acetazolamide is comparative, a non-randomized cohort study of 15 patients with acute central serous chororetinopathy treated with acetazolamide compared to 7 controls. Also, there is 164 patients treated with acetazolamide had faster subjective improvement and resorption of subretinal fluid with mean time to resolution of 3.3 plus minus 1 week in treatment group and 7.7 plus minus 1 week, 1.5 week in the control group. And there was no detectable difference in final visual acuity or recurrence rate between the two groups. Mineralocorticoid antagonist, the introduction of drugs such as spironolactone and eblironone in the treatment of central serous chororetinopathy has been founded on the base of pathogenic mechanism involving aldosterone mineralocorticoid receptors and choroidal hyperpermeability. Information regarding the effect of spironolactone in 18 patients with central serous chororetinopathy lasting for more than 3 months were treated with 25 milligrams of spironolactone twice daily up to 12 weeks. The subretinal fluid decreased from 219 to 100 micron, and total central thickness reduced from 405 to 287 micron, and parallel statistically significant improvement in best corrected visual acuity from baseline value of 0.3 to 0.2 could be registered. Also, there is 2 recent retrospective studies provided evidence of beneficial effect of oral eblironone on best corrected visual acuity improvement and the reduction of height of neurosensory detachment. Reported statistically significant improvement from the baseline of best corrected visual acuity of 0.4 logMAR to 0.2 at 3 months, and significant mean reduction in subretinal fluid by 100 micron in 14 patients. Only trend in the mean reduction of choroidal thickness was corresponding observed. Excluding the analysis of choroidal thickness, similar results were achieved by a second study in retrospective analysis carried out 13 patients. Both studies corroborated the outcome of previous prospective study with 3 months of follow-up performed and similar small population study also. At 3 months compared baseline value, the subretinal fluid had significantly decreased and best corrected visual acuity had significantly improved. Considered all the study, a complete neurosensory detachment resolution was detected in 35 to 67% of cases, and no significant adverse events were registered. This patient had bilateral chronic central serous chororetinopathy with diffuse RBE changes. Also, he had gravitational effect of subretinal fluid. He was subretinal fluid and intraretinal cystic changes in the right eye, also huge cystic changes in the left eye. After start of oral eplerenone therapy 50 milligram during 1 month, then decrease it to 25 milligram per day. Major decrease intraretinal cystoid edema was observed in both eyes. This patient also bilateral chronic central serous chororetinopathy observed with subretinal fluid and intraretinal cyst in the left eye with subretinal fluid also. After start of oral eplerenone 50 milligram per day for 1 month, then decreased it to 25 milligram and was maintained under lowest possible dose. Progressive retinal reattachment and resolved subretinal fluid for both eyes. The continued medication at 6 months and 18 months after, and the patient was improved until this stage, completely resolved subretinal fluid in the right eye and remaining small cyst. It looks as defective cyst. Also, it can be used in acute persistent subretinal fluid more than 4 months. Like this patient, 50 years old patient, treated with oral eplerenone 25 milligram daily with non-resolving subretinal fluid. Also, we can observe the choroidal thickening in this case with subretinal fluid. After 2 months, observed reduce the subretinal fluid and also decrease the choroidal thickening. Other oral treatment like systemic glucocorticoid receptors blockers as mifepristone, ketoconazole. Of these two agents, mifepristone appears to have small beneficial effect in treating central serous chororetinopathy, while ketoconazole had no effect. Also, antiadrenergic medication, there is to reduce the stress and adrenergic hyperactivity has suggested, but the studies are a small number and need further study to confirm the effect. Anti-platelets, aspirin, and antimetabolite like methotrexate, 5-reductase inhibitors, all studied before, but not confirm the effect of this disease on central serous chororetinopathy. We see in this table acetazolamide, there is a good result for decreased subretinal fluid and but no affecting the final visual acuity or decrease the recurrence. Some antibiotics used with omeprazole to treat Helicobacter pylori, but also not affected the final visual acuity or the recurrent attacks. Thank you.
Okay, thank you very much, Dr. Abdallah. Very interesting lecture for cover everything for the CSCR, this common disease. Just I would like to ask Dr. Abdallah, if you, regarding the incidence of CSCR in our society, do you think how often, or the risk factor mainly, maybe what other risk factors? Because you mentioned regarding the cardiac and steroids, but in your experience, more incidents, what is in our society?
I think there is risk for corticosteroid, either systemic or oral treatment, or local treatment also. It can affect and increase the risk of central cirrhosis. Also the psychological effect and stress life,
Yes.
it can induce central cirrhosis.
Yes, I thought here I see more patients with
Maybe
stress
there is
and
some genetic
yeah.
genetic factors, but undetermined.
personality type A can be
Type A
affected more.
personality
Yes,
also.
exactly. Just like to Dr. Saleh, Professor Saleh.
All right, thank you very much, Dr. Abdallah. Now, with after you reviewed the literature, you have your own cases. Would you recommend a patient came to you up front and he is a few days of central cirrhosis? Would you recommend? What would you recommend for him?
Regarding the acute central cirrhosis, I will observe the patient. No need for any intervention or injection, just to give him appointment after 3 months or 4 months. If there is persistent subretinal fluid, we can start by oral treatment like Diamox or eplerenone or spironolactone. The anti-VEGF is the studies is not strong evidence to give injection for those patients. But I think BDT is a good effect for persistent, long-acting disease. More than 4 months, he can go for BDT or oral treatment. He can start by oral treatment and to show if there is improvement or not.
You mean early oral treatment, like you will give him early Diamox, even without 3 months elapsed?
Before,
Yeah,
I
early
think-
on.
I
If he
think
comes bothered
observation-
with this,
the disease is spontaneously resolved, but need time.
yeah.
I think the observation is better for any acute central serous choroidal.
Because I have experience with few cases of chronic, and in fact there are changes in the RPE in the first eye, which accounting for decreased vision. I injected anti-VEGF. It was Avastin at that time, and there are in fact very rapid resolution and response to the treatment. Now, with some of the mineralocorticoid receptors activation, producing VEGF1 and also platelet growth factor, I think if I'm happen to use anti-VEGF, I will go for Eylea more, because Eylea has both anti-VEGF and
Inflammatory.
anti-platelet growth factor.
Also
This is-
anti-inflammatory
yeah.
effect.
Professor Saleh, do you try the anti-VEGF before argon laser with fluorescein, even the leaking outside the 500 micron?
You see, this is a point of choice, and in my opinion, if the leak is outside the 500, 600 micron, I will go for argon. Because this
Argon,
is, yeah, this is now you are even very negligible incidence of endophthalmitis, or
Yeah.
and also there is no very strong evidence of the VEGF as a main drive. I would for outside, for leakage outside the central fovea, I will go for myself for either argon or subthreshold dye.
Yeah. Just to make this point regarding the resident, still we are observation, Dr. Abdullah mentioned, then argon laser, if the leaking outside the 500 micron, then we can go for other options.
Absolutely. And also one point regarding when you are choosing argon laser, the aim is not, in fact, to have like in focal or PRB, like a white reaction. No,
Yeah.
it is like, if you think of like grid, it is only very faint gray reaction, so that we will not disturb the RPE, chorioretinal factor, or and the sort of the openings in the Brooks membrane, because I have seen central serous choroidal neovascularization complicating a treated or a laser treated central serous.
Yes.
It's difficult to say, is it just because of the disease or because of the laser?
Yeah.
Because we know even untreated central serous can have choroidal neovascularization, as Dr. Rubai told us. But now I think when you have aggressive laser, this definitely will be a factor in complicating. And if the spot or the leaking spot is somewhat closer to the fovea, even expansion of the
Yes,
scar
fine.
can retard vision as well.
Yeah. Exactly. Dr. Yahya?
Yeah, I have comment regarding the BDT. So the BDT still is valid options for subfoveal leak. So if you have like a subfoveal leak, I think the BDT is a good option in such cases. For myself, at least, I would not try systemic medication. I would go for BDT in such cases. Yeah, have fluence. Yeah, all the patients have
Or
fluence.
non-resolved.
Yeah, it's chronic, long-standing cyst.
Regarding the micropulse, any experience? Micropulse, subthreshold, if the leaking within 500 micron?
No, actually, I never tried in such
Never.
case. No.
Nobody. Any more question? Okay. Cool.
My question, if you have encountered one patient, for example, connective tissue disease, and he's on steroid, and they cannot wean him off from steroid, and what's the best option for such patients? They keep coming for recurrent attacks of CSR.
I think should be to discuss with the patient for the option of treatment to DC the corticosteroid or tabaret to the lower dose effective of for his main pathology.
Sometimes they come at least with 10 or 5 milligram of oral prednisolone, though they still have recurrent attack of.
No, I think there is many options for another anti-inflammatory medications to avoid steroid if the patient have the central serous choroidopathy, especially with recurrent attacks and persistent subretinal fluid. It can affect photoreceptors and the patient can go for blindness.
Thank you.
Okay. Any more questions?
Yes. I would like to ask about, thank you, Dr. Abdullah, for a nice talk that you presented. I would like to ask you and Dr. Ammar about the subretinal deposit. How does it behave? The one you shown on of the OCT, that thick subretinal deposit. Does it disappear immediately? Does it, if the fluid is gone?
The subretinal
Deposit.
deposit.
The thick deposit, elongated photoreceptor layer, and there is subretinal deposit. With the treatment, does it go immediately? Does it take time?
I think there is some subretinal deposit stay a long time, like scar subfoveal formation, especially in the chronic cases. Behave as the scar formation.
So this material actually it's a shaggy photoreceptor. So we expect with time, it's going to be resolved with time. So if you have the retina go back to the RPE, the RPE will take care of these shaggy material, which is the outer segment of photoreceptors.
Any more question? Okay. Thank you very much, Dr. Abdullah. Thank you.